Good morning. Thank you for being here for our plenary. I have the pleasure of introducing our first speaker, Dr. Laurence Grummer-Strawn, who will discuss how the WHO and AAP can collaborate to support optimal infant feeding. Dr. Grummer-Strawn is the coordinator of infant and young child feeding at the World Health Organization, where he leads the Baby-Friendly Hospital Initiative, the International Code of Marketing of Breast Milk Substitutes, and the Global Breastfeeding Collective. He previously served as chief of the nutrition branch at the Centers for Disease Control and Prevention. Dr. Grummer-Strawn has authored over 150 scientific publications on vitamin and mineral deficiencies, breastfeeding, and child growth. Please join me in welcoming Dr. Laurence Grummer-Strawn.
Thank you very much. It's wonderful to be with you today. Good morning, everyone. Happy to talk about how WHO and AAP can come together in a critical juncture for both of us, which is the support of breastfeeding. Last year, the WHO, in collaboration with UNICEF, launched a revision of the Baby-Friendly Hospital Initiative. And I was asked here to come and share with you some of the information about why we made that revision and what some of the key changes are to it. I have no disclosures to share this morning, no conflicts of interest. Let's start with a little bit of a background about the BFHI. The history of BFHI actually goes back to 1989. It was a publication jointly with WHO and UNICEF on the unique role of maternity services in supporting breastfeeding. And it was originally actually written as more of a text-type document talking about the kinds of things that need to change in clinical practice. And it was actually an afterthought that the 10 steps were added into the document. It was kind of a communications as it went through final clearance steps. So someone said, can't we kind of boil this long text document down into just some key points of what everyone should remember that they ought to do? And so it was kind of stuck in at the very last minute. Here are the 10 steps to successful breastfeeding. 2 years later, after the document was published, WHO and UNICEF came together and said, well, how are we actually going to roll this out to make this the standard of care for babies? How are we going to actually get good uptake of these 10 steps? And they came up with the Baby-Friendly Hospital Initiative. It was launched in 1991. And the idea was to designate facilities that could demonstrate they were adhering to the 10 steps as they were recommended 2 years earlier. As part of that designation, they also said that facilities needed to adhere to the Code of Marketing of Breast Milk Substitutes. 2009, there was a very minor revision to the way the initiative would be operated, a little bit of a reinterpretation of some of the steps, but no real reconsideration of the steps themselves. And so in 2016 was the first juncture at which WHO came together with UNICEF and member states of the World Health Organization to say, how are we doing with this initiative? Are we actually doing what we said we were going to do? Are we actually implementing the 10 steps in the way that they ought to be implemented? So one of the things that was part of that review was to consider, well, what is the evidence? Are the 10 steps actually evidence-based? And we don't have, on these kinds of things, typically a lot of RCTs, but there was one very important randomized control trial that randomized facilities to become designated as baby-friendly, go through all of the 10 steps and change their practices, versus leaving some facilities with their standard of care. And that initiative was hugely successful in increasing exclusive breastfeeding. In the control facilities, they had a 6% exclusive breastfeeding rate at 3 months, as opposed to among those that actually did go through the intervention, 43%. Huge success when all of the steps actually were implemented together. There was a systematic review that was published just a couple of years ago that pulled together 58 studies from 19 different countries and really documented that the 10 steps themselves do increase breastfeeding rates. The more steps that facilities adhere to, the better their adherence, the better their success with breastfeeding. But particularly step 6 about supplementation, avoiding supplementation when it is unnecessary and not medically indicated, was critical to success. And step 10, getting that community support when patients left the facility, was critically important. Just want to put up one of these studies that was included there to show there really is a dose-response kind of effect here. In this study, among women who all said that they wanted to breastfeed for at least 2 months, we tracked what percent of them had stopped in the first 6 weeks? They had failed to meet their goals with breastfeeding. And if they did not adhere to the 10 steps in those first 24 hours, 30% of them were not able to continue breastfeeding out to 6 weeks. On the other hand, if we got things right in those first 24 hours, the failure rate dropped down to only 3%, with a nice dose-response effect along the way. So when we looked at how has this initiative actually been implemented around the world, what we found was that very few countries were really able to make the initiative scaled up. As of 2017, globally, we found that only 10% of facilities had been designated within the last 5 years or been redesignated or reassessed in that time period. And in fact, you can see on this map, very few countries were able to achieve even a majority of births adhering to the 10 steps. So in that context, we said we really need to take a closer look at how are we doing with the initiative. And WHO launched into a dual system, basically, of looking at both the evidence for the 10 steps themselves to make sure we're putting out good clinical guidelines, as well as looking at the implementation and the guidance that we give to countries on how they should implement the initiative. So the guidelines process is a very systematic way that WHO goes through guidelines, making sure that we have a clear guidelines process that is overseen by a scientific body at WHO, that there is a guidelines group that comes together among the experts around the world that has to be multidisciplinary, multinational, representing all regions of the world, to really look carefully at the evidence. And they have to go through a systematic literature review on all of the questions that they want to look at. And so this body actually pulled together 13 systematic reviews looking at the 10 steps and sub-steps within them to make sure that what we're recommending truly is evidence-based. When that document was finished, it went out for peer review and finally was published as a clinical care guideline in 2017. Simultaneous to this process, we also looked at the guideline, the implementation guidance on how this actually should be carried out as a program. And this was done by a separate review group that looked at case studies around the world and actually pulled together 15 case studies and 22 key informant interviews to really understand how was the initiative being implemented. In addition, we brought together 130 countries from around the world to have a congress in WHO to discuss how could we improve the initiative? How could we actually get better scale up? How could we make it more sustainable? And those groups met in different rooms and had lots of different languages, came back together and shared their information. And it was out of that rich sharing across multiple countries that we actually developed a draft of the guidance, took the guidelines on what was really evidence-based and fed that into so that we could revise the 10 steps. That document was then completed and sent out for public comment. Lots of external comments were provided to that, and we finalized the document and published it in 2018 as an implementation guidance document. So the document includes two things. It's a revision of the 10 steps, as well as a revision of the operational guidance for countries on how they should implement the initiative. On the 10 steps, each of the 10 steps in concept still seemed to be evidence-based. And so there was still reason to maintain the structure of the 10 steps. But they were regrouped to think about critical management procedures, such as how do you train your staff, what kinds of policies need to be in place, what kinds of systems are needed at the facility level to support the steps, but then other steps that are much more clinical. People got confused about, well, how many steps should I do? Well, how do you actually compare should you have a policy versus should you have rooming in? And so we actually needed to think separately about the clinical practices from the critical management practices. We won't have time this morning to go through all of the changes to the 10 steps. Most of them are refinements in what is emphasized within the step rather than changing the overall concept. But we will go into a few of them that are more important changes. Within step 1, that was about the policies and the infrastructure of the facility. One of the most important things that we did was to incorporate the code of marketing of breast milk substitutes and subsequent resolutions as part of the 10 steps. What we found was that many facilities were saying, oh, we still adhere to the 10 steps of successful breastfeeding, but we want to take free supplies from formula industries, or we still want to provide our mothers with free samples when they leave. That was not acceptable for baby-friendly designation, but it was not considered part of the 10 steps. And so this was reframed to say, no, this really is a critical responsibility of all facilities. When the code was originally written in 1981, it called on healthcare workers and healthcare systems to adhere to the code. Many people have said, oh, we do adhere to the code because we follow the laws of our country. But from a WHO perspective and a UNICEF perspective, that's not good enough. Healthcare providers themselves are responsible for not participating in the marketing of breast milk substitutes. They need to be protecting the health of mothers and babies, and therefore protecting breastfeeding, and they should not be seen as marketers of breast milk substitutes. And so it calls for no free or subsidized supplies of breast milk substitutes or feeding bottles or teats, no advertising of breast milk substitutes in any form within the facilities, no display of anything that shows the brand of companies that make breast milk substitutes, no discount coupons being given out, no samples to be used either in the facility or to be used at homes. In addition to the code, we also refer to subsequent World Health Assembly resolutions, because since 1981, the World Health Assembly has come back repeatedly and said, how are we doing in terms of implementing this? And are there things that we actually missed in 1981? So they update and refine and clarify some of the issues there. One of the most important clarifications was in 2016, which really tried to clamp down on conflict of interest issues. And so now WHO is really focusing a lot on the conflicts of interest, particularly between manufacturers of breast milk substitutes and healthcare providers. And so it is certainly of great concern to us when we see close relationships, funding coming to organizations, funding coming to meetings, funding coming into the education of our healthcare providers that is actually shaping the way that they think about infant feeding, shaping the way that they prescribe for their patients, the way that they have their education and the communications that they have around issues of infant feeding. And so we really want to clamp down and close the conflicts of interest that exist there. A second change that we've done to the steps is to add a step about internal monitoring within facilities. What we found was that the external assessment process that was often seen as designation of a facility as being baby-friendly worked well for those facilities that stepped up to be designated at the time they were being designated, but A, it did not reach enough facilities. Many facilities just never voluntarily stepped up and said, we want to be designated, and therefore they didn't get all of the technical assistance, and they didn't necessarily adhere to all of the 10 steps. And B, many times that was not sustainable over time, so they did not keep their practices in place. So they changed them for the purposes of quality assurance and the visit that they might get to get designated, but then 2 or 3 years later, they forgot about some of the things that they had done. New staff came in, they didn't get trained. Many things fell away. And what the quality improvement literature has documented is that for us to maintain good quality services, we need to have internal monitoring systems so that we can track over time what is getting better, what is getting worse, where can we make improvements, and how are we doing with regard to that. So the steps now call for regular charting of a number of the steps and regular interviews with mothers so that we're actually tracking what their experiences are with care, and then documenting that and reviewing it on a periodic basis. Step 2 has changed its focus, whereas previously it was really a focus on getting training itself and being trained in the 10 steps. We're now focusing much more on competency assessment because we learned that many times people would actually sit in an audience and listen to the 10 steps, listen to the things that they're supposed to do, but not actually change their practices. And so we need to make sure that they're actually obtaining the skills that they need and that we're doing competency assessment to make sure that they are able to carry out the 10 steps. Step 6 is not substantially changed, but the emphasis is a little bit different. We really do want to make sure we are not providing routine supplementation to breastfed babies, but we also need to make sure that our clinicians really do understand the reasons when there is need for supplementation. The initiative has been criticized on the basis of there are babies that sometimes do need supplementation and don't get it. And so we don't want to have an initiative that only says never supplement babies, but we also don't want to do it inappropriately. And so there needs to be much more education about what are the appropriate reasons for supplementation, appropriate reasons for the use of breast milk substitutes. And when we do actually need to supplement a baby, look to other alternatives, such as expressing the mother's milk, such as providing donor milk to those mothers. We also need to provide support for those mothers who do need to use formula or choose to use formula, and make sure that our facilities are also supporting them. There's been a lot of controversy about changes to the Step 9, which used to be a ban on the use of bottles, teats, or pacifiers within facilities. And when we went through the systematic literature reviews, what we found was that there really wasn't a strong evidence base why these could not be used. There are still some concerns, and they're context specific. We have concerns about hygiene, particularly in places where there's not safe, clean running water. Concerns about recognition of satiety cues, particularly with regard to pacifiers. If the baby has a pacifier in their mouth, then the mother might not actually recognize that this baby is showing cues that they need to be fed. So we want to counsel mothers on when they are appropriately used and how to use them appropriately, but we can't automatically ban them. Particularly in the application for preterm and low birth weight babies, there actually is good evidence that non-nutritive suckling, such as through using a pacifier, is actually beneficial to these babies. And so we, of course, don't want to have an outright ban across them. Step 10 has also changed slightly in that we don't emphasize that the facility is responsible for the fostering of mother-to-mother support groups in the community, because we recognize that most facilities don't actually work out in the community. They need to collaborate with community organizations, but their responsibility really is to provide optimal care for the patients at the time that they are within the facilities. And so we focus much more on discharge care, making sure that there is a good referral network and that mothers are indeed followed up after they leave. There are multiple ways that that kind of support in the community can be offered. It is not just through mother-to-mother support groups. We also need to have it through primary health care, through good medical systems, but also non-medical systems, home visitors, community workers, health workers that actually go out and visit to the families, lactation consultants. So there are multiple ways that we can provide that community support. The responsibility of the facility is to make sure that mothers are able to get that support. When we step back and look at how the initiative is supposed to be implemented in countries, we really have two major foci. One is we need to be thinking about national programs in a way of how do we reach universal coverage? How are we going to make sure that every facility in a country recognizes it is their responsibility to provide evidence-based care for its patients? Doing that through a designation process hasn't proven to work well. Only do we get volunteers and those that are champions saying, yes, we want to get this done, but all of the other facilities are not yet stepping up. And so we need to be thinking about ways to do it in an across-the-board fashion. We also need to be thinking about sustainability of this. The old initiative was very resource intensive, with external resources coming into countries to manage the designation process. And while that's fine for countries that have the resources to do that, we really think that we need to be thinking about a different model. And so we put forward this model of multiple things that a national breastfeeding program needs to take on. There needs to be coordination of the support in maternity facilities, but we need to be integrating the standards of the 10 steps into professional standards of care. We need to be building it into the competency assessments and the pre-service training of healthcare providers. We need to streamline external assessments so that they're not so costly. We need to find ways to incentivize facilities to take on these changes. We need to provide technical assistance not only to facilities that have stepped up and asked for it, but in a more systematic way so that we're really helping all facilities to go through the changes that are needed. We also need to think sustainably about how do we do this for national monitoring, how do we do advocacy and financing so that the initiative does not die away and it cannot be sustainable. Let me just finalize with summarizing some of the key points here. We want to make sure that you understand baby-friendly needs to be the responsibility of every facility. The 10 steps are applicable to all babies, including preterm, low birth weight, and sick babies. They may need a somewhat different clinical care, but the 10 steps themselves are all applicable in their context. We need to integrate the standards into standards of care. We need to use a quality improvement approach, including ongoing internal monitoring. We need to make sure that all healthcare providers are competent in providing appropriate services. We need to build internal monitoring systems, and external assessment is still valuable, but it needs to be provided to all facilities so that we're ensuring the quality of care across the board for everyone. I want to thank you very much for your attention this morning.